in terms of decreasing numbers of cases. But still, there still is a lot of virus out there. So I think we need to be thinking about all we can do to protect ourselves, protect our loved ones, and all those around us from COVID-19. So I'm going to talk a little bit about some of the basics, with focusing on a couple of specific parts of our prevention strategy. The first few points are really messages that have been reiterated over the last year. We know that those individuals who are sick are most likely to infect other people. So really, if you are sick, and certainly if you're diagnosed with COVID-19, test positive, then staying home is really critical. The distancing is also a big message. The virus travels in those respiratory droplets, can travel up to about 6 feet. And that's why we really emphasize, trying to keep distance from others as much as possible. And then the other potential method of transmission that we're aware of is contact. So that's direct contact with respiratory droplets through directly touching someone who has who's infected with COVID-19, but also shared surfaces. So thinking about touching objects or surfaces that someone else may have touched recently. Fortunately, as we learn more about the virus and how it spreads, it seems like contact and surfaces are much less common in terms of infection risk. It's really predominantly through respiratory droplets, from coughing, from sneezing, from talking. That's really what the primary way that the virus is spreading, which is why masks and face coverings have become so critical in our preventive measures. And I'll talk about that in a little bit more detail. I can talk a little bit about COVID-19 treatments. I get a lot of questions, what's happening in hospitals and what kind of treatments are becoming available for people outside the hospital. And we've had some pretty important advances that I'll talk about. And then lastly, we'll talk about the vaccine, and we can touch a little bit on some of these variants that we keep hearing about in the news that are being identified, and what they might mean for the future in terms of what we see happen with the virus spread in Connecticut, the United States, and throughout the world. So just a little bit of more detail on masks and face coverings. I think the masks have been demonstrated to have a few benefits. The initial rationale for wearing masks is that we knew that a lot of people were, this was back a year ago, people were contagious and not actually having symptoms. So the concern was, what can we do to prevent those people who are not symptomatic but still infected and may infect others from, what can we do in terms of blocking that? And that's where the mask originally had its place. So you can see in this picture here, that person who is not symptomatic but infected, as they talk, they're sending out all these respiratory droplets. They can have virus, but when they wear a mask, the number of droplets that make it through the mask is very much less than had they not worn a mask. So really less risk of infecting others. And what we've learned over the recent months is that the masks not only have this effect, but actually protect us. So if a person is wearing a mask, even if they are exposed to the virus, it blocks them from ingesting the virus and becoming infected. So really two major roles of wearing a mask. And now, we've gotten more and more understanding of different types of masks and what works and what we should be avoiding. So in terms of what to avoid, there's a couple of important points. So many of you have probably seen these masks with the exhalation valves. So these are masks that can be worn, and they have that little valve that allows someone to breathe out, and they're more comfortable. But important to realize that these masks don't really prevent that whole initial goal of blocking the respiratory secretions from coming out of people's mouths. So wearing them is really not effective for that purpose. So they're really discouraged as a measure to prevent spread. The other thing that we've learned about is that layering and quality of the mask is really important. So there have been multiple studies now to demonstrate that thin masks, so thin gaiter masks or bandanas, kind one-layer cloth covering are less effective, both in blocking droplet spread, but also in protecting the person wearing the mask. And I will mention, we hear a lot about these N95 respirators that we use in the hospital. So these are special masks that have a very high level of filtration to them, and they are effective in blocking large quantities of droplets of different sizes. So we use them in situations where we are doing things with patients that can produce a massive amount of droplets. So like, for instance, if we have to help a patient breathe, put them on a breathing machine, those kinds of things produce tons of droplets, and that's where these N95 respirators are most helpful. Also important to know that they need to be fitted on an individual basis. So really not something that should be worn outside of the hospital setting in the community, but really specifically designed for purposes in the hospital. So what are some of the other important concepts about masking? So double masking, right? This has gotten a lot of attention. We know that one layer of mask thickness is not as effective as 2 layers. And what does that mean? How do we interpret that? So I think that double masking does have some value to it, but I think it's a balance, right? So there's this study that was performed by CDC and just published a couple of weeks ago that really raised or sort of brought this topic to light. Was a study that was done where they compared 3 different scenarios, one in which a patient, or I guess it was a mannequin, wore a single layer mask, one in which the mannequin wore a single layer mask covered with a cloth mask, and then another one where they wore a regular mask, a simple face procedure mask, and did some things to it to help make the fit better. So they made, knotted the sides to help it kind of close up against the face, and kind of tucked in the sides so that there weren't any gaps in the mask. And what they found was that the amount of droplets that passed through was significantly decreased in the people that wore either the double layer mask, so a single mask covered by a cloth mask, or wore a single layer mask that was better fitted to the face. So I think there's a few key messages regarding masking. First, when do I wear a mask? So I think masks are most important in indoor spaces. So if you're indoors and you're going to be around people that are outside of your household, that's really the right time to wear a mask to protect yourself and protect those around you. In terms of outdoor masking, I think the key is whether or not you can maintain that distancing between one another. Even if you're outdoors, the risk of spread is much lower. But people who are kind of forced to be in close contact, I think the mask still has its role in that kind of situation as well in preventing droplets from spreading. The other key pieces of the mask, it's really got to fit well, and it should be a good quality mask. So, I think this most recent study from CDC should emphasize both of those points, that wearing a high quality mask, one that has good thickness, at least 2 layers of protection, as well as something that fits well to the face. So one of the main benefits of wearing the cloth mask over a single mask is it helps kind of conform the mask to your face and eliminate some of those gaps between the mask and the face where droplets can potentially enter. So, I think that's kind of my overall take on masks. And if there's additional questions, I'd be happy to get into that in more detail. But the masking, I think, is really important. It's going to be a key measure, certainly for now and for the near future. Whether it's going to be something that we'll be doing for a prolonged period of time is still to be determined. But for now, I think masking is going to be a really important step to really shutting down the virus spread and keeping everyone from becoming infected. So I'll touch briefly on treatment. A lot of questions about that. So what are we doing to treat our patients in the hospital? So there's been a ton of studies that have been done over the last year. Some of the things that we were initially using, like hydroxychloroquine, unfortunately, once they were actually studied, did not show benefit in treating patients with COVID-19. Dexamethasone is the medication for which we have the best data, and we use this pretty universally for any of our patients hospitalized who require any supplemental oxygen. Remdesivir, that's an antivirus medicine that we can give early on in the course of infection to really drop down the amount of virus that replicates in the body. and help patients recover more quickly. These next two medications, baricitinib and tocilizumab, those are immune suppressing medicines. So what we've learned is that when it comes to illness from COVID-19, it's not just about the virus infection, but also the immune response. And people who get really sick have a very overactive immune response that causes them to become sick and can lead to some of that inflammation and the damage in the lung in response to an infection. And these medications kind of slow that down a little bit and prevent some of the damage in our lungs for people that get severe COVID pneumonia. And then, supportive care and oxygen is all a huge part of what we use to take care of patients. I'll point out one newer therapy that's become increasingly available in the recent months. You may hear about this in the news, the monoclonal antibodies. So these have become very important in taking care of our patients who have mild illness to prevent them from progressing into more severe illness that requires them to be hospitalized. So these antibodies basically block the virus from attaching to cells in our lungs to cause pneumonia and cause people to get sicker. So we use these relatively frequently, and hospitals throughout Connecticut have these monoclonal antibodies, and because they're most effective when given early on, they're important for the public to be aware of. So if an individual is out in the community and develops symptoms and tests positive for COVID, particularly if they have any of those high risk conditions like older age, some of the medical comorbidities like cardiac disease, underlying lung disease, and they are infected with COVID, we give these medications very rapidly in order to prevent them from progressing. So, if any of you or any of your friends and family, or you hear about anyone in the community who tests positive and has one of these conditions, seek these out. The hospitals throughout the state do offer these, and I think they've been demonstrated to be very effective in preventing the progression of illness to needing hospitalization. But I'll focus primarily on the vaccine. So, a lot of the main question that I get is, how did this vaccine become available so quickly? We never hear about vaccines that are developed with this level of speed. This virus just appeared a year ago. How did we get to a vaccine that was available in December? So I think, Operation Warp Speed was a big part of that. It was a huge investment that the government made in rapidly developing and producing a vaccine. So several companies were supported through this to go from the phase where we were able to identify and get the genetic sequence of the virus to the point where we were able to develop a vaccine and produce the vaccine. And I think that was really critical. But I think it's also important to know, which phases of the vaccine development were actually accelerated. So it's really going from that discovering the genetic code of the virus to making the vaccine. That required a lot of investment in the science and sort of the research to be able to get to that phase. And then the initial production of the vaccine also required quite a bit of investment. But then it's important to know that the phase 3 clinical trial, which is the large 60,000 person study that was done to ensure the effectiveness and the safety of the vaccines, was not accelerated. In fact, it was done with a very strong and very careful methodology that helps provide that reassurance that we need in order to really feel confident in these vaccines. And then, some of the additional acceleration came once the vaccines were demonstrated in the clinical trial to be safe and effective in really ramping up the production and the distribution process, which is where we are right now with getting these vaccines out. So, I think, it's really critical to know that phase 3 clinical trial was done as meticulously and carefully as any vaccine trial that's been done to date. And the number of people that enrolled was as large as the other vaccine studies that have been done. So I think that is reassuring and providing confidence in these vaccines. So here are the two that are currently available, the Pfizer vaccine and the Moderna vaccine. They're quite similar, both in terms of the way that they work, but also their effectiveness and safety. Here's kind of a brief description of how they work. So these, you may hear the term mRNA vaccines, and essentially these vaccines are a little bit different than the traditional vaccines that we use. So in most vaccines, the person receiving the vaccine gets either a little bit of the virus that's been kind of killed or inactivated, or they get a little piece of a virus particle as part of the vaccine. You get the vaccine, it sort of revs up your immune system to make the antibodies and those T cells that protect you if you're ever exposed to the virus again in the future. These vaccines actually work on an earlier step in that whole process. So rather than containing a piece of the virus or the actual virus that's been killed, they actually contain a bit of genetic code that allows our own body's sort of natural protein making ability to make those particles that are sort of a small piece of what a virus might look like. You may have heard the term the spike protein. That's part of the coronavirus. So we make a little bit of the spike protein, and that's what stimulates our immune system to generate the antibodies and the T cells that help provide that protection. So these mRNA vaccines, even though they're relatively new, they have been studied and used in other types of situations. Some of these other viruses that I have included there are kind of rarer viruses where these types of vaccines have been used. And interestingly, they've also been used in cancer treatments. So it's a concept where rather than give the mRNA to make a piece of the virus, you actually give a little bit of the mRNA that makes part of a cancer cell, and that stimulates your immune system to kind of go on the attack and kill off any cancer in the body. So same principle, but a little bit of a different way to use it. Some of the most common questions I get about the vaccines. So do these mRNA vaccines, can someone get sick with COVID-19 from them? So these vaccines don't contain any virus and can't cause any infection. So you can't get the COVID-19 infection from a vaccine. The other question I get is, these are mRNA, the genetic code. Can they affect our own DNA and cause harm that way? And important to know that based on the way that these vaccines work, the mRNA doesn't actually go into the nucleus of the cell where the DNA is housed. So it can't cause our DNA to mutate or to, cause cancer through mutations and that sort of thing, because it doesn't work. It doesn't even get into that part of the cells. And then, some of the question is, does this mRNA stay in our body for a long period of time? Can it cause problems down the road, months from now, years from now? And the answer to that is no. We have sort of natural chemicals and enzymes in our body that will immediately break. Once the mRNA does its job in making the protein that makes the immune response, it immediately gets broken down by our cells and sort of disappears. Some people liken it to a Snapchat message. It basically shows up, does its job, and then it's gone. So I won't go into all the details on the vaccine efficacy. Here's some of the data from the Pfizer and the Moderna vaccine. We hear about that 95% efficacy, which is really remarkable in terms of its ability to prevent clinical infection. So remember, these vaccines were studied primarily as their effect to prevent people from getting sick with COVID. So the outcome that was measured was people who had developed symptoms and test positive for COVID. And these vaccines were remarkably effective in preventing that from happening, which is really critical because we want these vaccines to protect us, prevent us from getting sick, prevent us from needing to be hospitalized, and prevent mortality and death from COVID. So, some of the questions that linger. So, how long does the immunity last? A lot of questions about this. I think we don't have an answer to that because these vaccines, just like COVID, are relatively new. And I think, fortunately, what we're learning is that as we study people who have had either a natural infection with COVID or have gotten the vaccine, we find that those antibodies do last for several months at least. So the folks in the Moderna trial now, we have over 4 months of data to show that those antibodies stay at high levels for at least 4 months after getting vaccinated. I suspect it will probably be longer, hopefully much longer, but something that time will tell. And if we do find that over months and years that the antibodies drop and we still need to be protected from COVID, there may be a possibility of needing a booster at some point in the future. I think, we don't know. But it is also important to know that these are 2-dose vaccines, and the way that these vaccines work, it's really important that that second dose be administered, because that helps provide a real boost to the amount of antibodies that we have, as well as affecting, but with that higher number of antibodies, they'll provide a longer term response, a longer duration of protection. So really important to get that second dose of these mRNA vaccines. I will talk about another vaccine where that the way it works might be a little bit different. So, we know that these vaccines are 95% effective in preventing illness from COVID-19, but one of the questions is, can people, after they get the vaccine, still become infected but maybe be asymptomatic? And can those people spread the virus to other people? So that's really a critical question. We're so grateful that these vaccines prevent illness, but do they also prevent transmission? So this is something that, we're still collecting data on this, but unfortunately, now that these vaccines have been rolled out worldwide, we've gotten more and more data, and the data is really encouraging in this front. So we know that people who are vaccinated technically still can become infected, but the risk of that happening is dramatically lowered, and that's really important. The other thing that we're learning is that when people who are vaccinated do become infected, the amount of virus that they shed is much less too, so it makes them much less contagious. Again, it's not a guarantee that someone can't become infected and potentially spread the virus to others without having any symptoms after a vaccine, but it really makes their contagiousness much lower. But until we get enough people vaccinated, until the virus levels drop low enough, that's why we're still recommending for now wearing the mask, maintaining the social distancing, avoiding crowds, all those preventive measures. In order to prevent the possibility that someone could still spread the virus to others. But I think, the findings that we're seeing, especially, other countries that have moved a little bit closer towards sort of countrywide immunity, countries like Israel and the UK, where a large percentage of the population has been vaccinated, have really started to demonstrate that the amount of asymptomatic transmission after a vaccine is extremely low. And I think that's really encouraging. Both in terms of protecting the public, but also, as we think about getting to a point where we can start to, de-escalate some of those preventive measures in the future, I think that's really what's going to get us there, is through these vaccines. So I think it really exciting findings, and I think really optimistic for what these vaccines can do. So get some questions about short-term safety and allergic reactions. I think when we think about side effects, very important to be aware of what happens. So what we know about these vaccines is part of the reason that they're so effective is because they generate a really strong immune response. But as part of that, one of the secondary effects is that people can get symptoms as part of that process. So, folks who get their vaccine, particularly the second dose of the vaccine, which really revs up the immune system, do sometimes get symptoms. We hear about fatigue, some headaches, some low-grade fevers that occur most commonly after the second dose. And it's important to know that that doesn't mean that you're becoming infected with COVID virus. It means that your immune system is responding to the vaccine as you would want it. It's cranking out those antibodies, it's cranking out those protective immune cells. And part of that, you do get symptoms. Typically it lasts for about 12 to 24 hours, and then people kind of go back to feeling normal. And then, I get questions about, what should I take, Tylenol or ibuprofen afterwards? And the answer is, if you do get those symptoms, you should. That's a sign that your body responded well to the vaccine, that, you are generating all those protective cells and the antibodies. And if you do get symptoms, you can take those medications at that point. What we're generally advising is that people not take them in advance. So some people are telling me, I'm going for my vaccine tomorrow, I want to take some Tylenol or some ibuprofen beforehand. And part of the rationale is that those medicines work by blocking some of the inflammation. And there's some concern that if they're taken right before the vaccine, it may actually reduce the ability to build up those antibodies. So it may kind of blunt that response that you want from your immune system after getting a vaccine. So generally, recommend against pre-medication with these kinds of medicines. But certainly after you get the vaccine, if you start to get these symptoms, that means your body's already done it. You've already been making those immune cells. Then by all means, you can go ahead and take a dose of Tylenol or ibuprofen to help relieve some of those symptoms that have developed. A little bit on allergy and anaphylaxis. So, this has now been studied through our the VAERS system, which is the Vaccine Adverse Events Reporting System that CDC collects all this data on any adverse events. And I won't go through all this in too much detail, but essentially the rate of anaphylactic reactions, allergic reactions is extremely low. So ranging from about, the cumulative data is about 4.5 cases of anaphylaxis per million doses. So quite rare, a little bit higher than the flu and the pneumonia vaccines, which are about 1.5 to 2.5 cases per million, but much less than things like the zoster, the shingles vaccine, which has a much higher rate of allergic reactions. And again, when I say much higher, you have to keep it in perspective. This is like for the shingles vaccine, 9.6 cases per million doses. So pretty rare, but more common than with the COVID vaccines. Another few things that I'll mention is that in the data that's been collected, most, in fact, in some of the data series, nearly all of the people who had an allergic reaction to the vaccine had a history of allergy to either another vaccine or some injectable medication. So what we're recommending is that people that have had a history of a severe allergy to a vaccine or to a injectable medication, that they get observed a little bit longer after they get their COVID vaccine. So 30 minutes as opposed to the standard 15 minutes. And then, some people ask about long-term side effects. COVID vaccines have now only really been out there for a few months, so we don't have long-term data. But what I will say is that when it comes to long-term side effects from vaccines, the long-term is generally considered to be like a few months, which is when we see some rare reactions to things like the flu vaccine. You may have heard of things like Guillain-Barré syndrome, a neurological condition that can rarely occur after a flu vaccine. That usually occurs within the first 60 days. And fortunately, we're not seeing those kinds of side effects occur in patients who are enrolled in the Moderna or the Pfizer trials, which is good. But nonetheless, these trials continue to follow patients for years to make sure that there's no unusual findings or symptoms that come up. But I think it's very reassuring that at least in the first 2 months of follow-up, which is when we typically see the quote unquote longer term side effects from the vaccines, we haven't been seeing them with the COVID vaccine. So I think that's a really good thing. Some special populations, so people who have had COVID, how do we approach vaccinating them? It's according to the CDC recommendations, having had COVID is not a contraindication to getting vaccinated. And as I mentioned earlier, I think there's still benefit to getting that vaccine even after a COVID infection, in making kind of a stronger immune response, but also a longer lasting immune response by getting a vaccine. There's some data suggest that because it's a two-part vaccine series, the first dose kind of primes your immune system, and then it's that second dose that really boosts up those antibodies and those protective T cells to provide the immunity. That's why people tend to get a little bit more symptoms after that second dose. But with people who have had COVID, it seems like their first dose may have been comparable to their actual natural infection, and then when they get their first vaccine dose afterwards, they tend to get a really strong immune response and generate a lot of antibodies. There's some study underway that it's possible that people who have had COVID may not even need a second dose of the vaccine. They may have high enough levels of antibody after the first dose. So stay tuned. Again, at this point, the recommendations are still to get both doses, but it's possible that as we learn more, we may not necessarily need to give the second dose of these vaccines to people who have had COVID. And then the other piece in terms of the timing, so people who have had COVID need to wait at least 10 days until the point where they're no longer contagious before they get vaccinated. And they can wait up to 3 months. Natural infection with COVID seems to provide some short-term immunity during that period. So when vaccine is in short supply, as it is at the moment, you can wait a few months after having a COVID infection. Some other groups to consider: people who have gotten monoclonal antibodies, generally recommended to wait 90 days because there's concern that those antibodies may block the effect of the vaccine. So we don't want to vaccinate them right after they get a monoclonal antibody for that reason. And then people who are on quarantine after an exposure, generally recommend to wait until that 14-day quarantine period is over before you go ahead and get vaccinated. Some questions about immunocompromised folks or people with like autoimmune conditions who are on immune suppressant medications. So a couple of points. As I've been mentioning multiple times, the vaccine is not a live vaccine, so there isn't a risk of becoming ill from the vaccine with COVID, even if your immune system is weakened because it's not a live virus vaccine. There still is some question as to whether people whose immune system is suppressed are going to respond as strongly to the vaccine as someone whose immune system is not suppressed. I think still getting more information on that, but in my mind, there's definitely some protection there, and whether it's as high a level of protection, I think is still to be determined. But at this point, I'm still encouraging my patients who have immunocompromising conditions to go ahead and get vaccinated because some protection against COVID is better than no protection against COVID. So I think that's the general message, and those are the recommendations from CDC. A lot of discussion about pregnancy and breastfeeding. As is commonly the case in the vaccine trials, pregnant women were excluded from those trials, so we don't actually have the data from clinical trials to support effectiveness and safety during pregnancy. But on the other hand, there isn't a scientific basis to suggest that these vaccines would be harmful to mom or to baby. The vaccines, as I mentioned, once the mRNA does its job and makes that immune response, they don't linger in the body. They wouldn't get transferred onto the baby. They don't get into the nucleus and affect the DNA of the mom or the baby. So there isn't a scientific basis to suggest that there would be harm to either mom or baby. And what we do know, on the other hand, is that when pregnant women do get COVID infection, they have a much higher risk of developing severe illness and hospitalization. So it's a personal decision. I think certainly anyone who's pregnant needs to have that discussion with their obstetrician as to how to think about vaccine. But there's definitely a benefit to getting vaccinated and preventing COVID in this population that is at higher risk compared to the general population. So I'll mention one other vaccine briefly, this Johnson & Johnson vaccine. This works a little bit differently than the mRNA vaccines, but using the same principles. So rather than actually giving the mRNA as part of the vaccine, this uses a non-replicating virus to kind of deliver the mRNA to the cells. Again, the virus is non-replicating, so it can't actually cause illness, but it does bring that little bit of genetic code into the cell. The good thing is that because of the way it works, it generates a very high immune response after just one injection. So it looks like this will be a single dose vaccine, which is really important. And the other key piece is that because you're not actually using the mRNA itself, the freezing and storage requirements are not as strict. So mRNA, it needs to be stored at extremely cold temperatures and has a much limited stability when it's brought out into room temperature, and that is a real factor when it comes to getting vaccine out there to different groups when these storage requirements are so strict. So I think those are both really important aspects of the Johnson & Johnson vaccine. And on Friday, the FDA is going to be meeting to review this vaccine, and we're hopeful that it'll get authorized by FDA within the next week. Will start to become available. And then I'll just briefly talk about variants. This is something that's been in the news a lot. What do we know about these new variant strains? So generally speaking, coronaviruses by nature do tend to mutate. So it's not surprising to see that there's going to be some small mutations that can affect the virus. You may have heard about some specific variants. There's the B117 has gotten the most attention. This is a strain of virus that was first detected in the United Kingdom, and it has some changes to the spike protein that seem to make it more contagious. We're still understanding exactly why it's more contagious, but fortunately, it seems like the vaccine response, so the antibodies that are made from the vaccine are still very active against this variant. So, even though it can be a little bit more contagious, we can still really protect ourselves from it by vaccinating ourselves and ensuring that those around us are getting vaccinated. And then, these other variants, the South Africa variant, Brazil variant, have some different changes to the virus. And I think, we'll learn a little bit more about these. Fortunately, the South Africa variant does seem to be respond to the vaccine. The antibodies that are made may be a little bit less than what we see for these other variants, but still seem to be quite high, which is reassuring. But I think, as we do more and more testing for these variants, we'll learn more and more about them. But the bottom line is we're kind of in a race between getting as many people vaccinated as quickly as we can before these variants start to all emerge and raise concern about the vaccine becoming less effective. So right now, it really is that race against the variants to make sure everyone gets vaccinated. So I'll skip ahead a little bit. And we can talk. I think I see some questions coming in, so I want to make sure I have time for Q&A. But what I will say is that in Connecticut, we're really doing an excellent job with getting vaccine out there. So the state has really worked hard to get vaccines to those highest risk groups, particularly older folks. The initial focus on the nursing homes and long-term care has been critical, and I think that's been really tremendously impactful in what we're seeing in terms of decreasing hospitalizations and mortalities from COVID. So now that we've expanded to 65 and older, and soon we'll be moving to 55 and older. But I think the real goal is to just try to get as many vaccines in as many people as we can to provide a level of immunity for our state and to protect not just individuals, but also protect all of us in reducing the amount of virus that's out there. So I'll end at that, and I'm happy to take some questions. I see some questions kind of periodically floating in. So Carrie, I don't know if you'd like to kind of moderate that, and I'm happy to answer them as they come in.
Sure, I can read you some of these questions. With your experience, which vaccine has less side effects, Moderna or Pfizer?
So, I think at this point, we haven't really seen a significant difference in terms of side effects. It's really kind of variable person to person. These Pfizer and Moderna vaccines are so similar that they're way more similar than different. I think the main differences are the spaces between the doses. So the Pfizer is 3 weeks, the Moderna 4 weeks. But in terms of side effects, really not seeing a significant difference between the two. I will comment that what we are seeing is that younger people tend to get a little bit more symptoms afterwards than older people after the second dose, but that's been seen with both vaccines. So no real significant difference between the two.
Next one is, if you don't get any side effects after each shot, should you be concerned that you didn't get the antibodies?
Good question. So I'll share my own experience when I got the vaccine. I got my first dose in mid-December, my second dose in January, and I got the Pfizer vaccine because that's what we had available here at UConn. And I didn't really get many symptoms. So I was thinking that exact question. What if I didn't get a good response? But what reassured me was, when I looked in the data from the clinical trials, I saw that there were a lot of people who didn't get symptoms. So even though we hear a lot about symptoms, it really was a minority of people that actually got symptoms, at upwards of about 30 to 40% or so. So that meant that 60% of people didn't get any symptoms, and the efficacy overall was 95% still. So, I think that provided me some reassurance that even without getting symptoms, you still get protection.
The next question is, should I worry about, I'm not sure how to pronounce this, Ocrevus, O-C-R-E-V-U-S, that I'm currently taking?
So that's a good question. So that's one of the medicines that we use in people that have different kinds of inflammatory conditions, and I think it's a medicine that doesn't necessarily have that level of immune suppressant. So I think people on that medication would be expected to respond well, and I don't think there would be a risk necessarily associated with that medication because not a live virus vaccine, it wouldn't cause infection even in people that were on medicines that were more immune suppressing than.
Okay, next question is, what is your opinion on the governor's decision not to allow high-risk people to be vaccinated ahead of their general age groups?
So good question. I think, there's no perfect strategy with how to roll out vaccine. I think there's always going to be trade-offs. And I feel for people who are in younger age groups and have higher risk medical conditions because that group has been waiting, and I realize that. And I think the governor's decision was guided by a few concepts. First, his main overarching goal is to get as many vaccines out there as possible. because we know that if we get our Connecticut population vaccinated as quickly as possible, that'll provide protection not just for individuals but also for the whole state. I think the other piece is that it was becoming a little difficult to tease out different conditions that are at high risk versus not being at high risk. So like when we take something like heart disease, there are some heart conditions that are at higher risk, some heart conditions that aren't at higher risk necessarily. And kind of sorting it all out was becoming really a real challenge. And other states that have been using that approach of focusing on groups that have high risk conditions saw that really slow down the speed at which they can get vaccine out there. And there's other ideas as well that in generally speaking, the people with the higher risk conditions tend to fall in the older age groups, although it's not universal. There's certainly younger people out there that have higher risk conditions. So I think those were the kinds of factors that the governor used in making that decision. Again, not easy decision, and believe me, I feel for I have younger patients that have conditions that are high risk, and unfortunately they'll need to wait a little bit longer. But my advice to them is really just stay strong, stay vigilant. We know you've been waiting out there and doing all you can to protect yourself. And hopefully with this strategy, we'll be able to move very quickly along and get to all of our population as quickly as possible.
Okay, actually, that kind of goes to the next question. Johns Hopkins reported several days ago that we would reach herd immunity by April. Do you have any comment about that?
Well, I think that's a tricky question. Herd immunity is an important concept to be thinking about. How do we get enough people immune either through vaccination or through natural infection to protect ourselves? And I think it's hard to really make clear conclusions on that. Herd immunity, what kind of population should we be looking at? Should we be looking at herd immunity in the United States, herd immunity levels in Connecticut, herd immunity levels in the town of Berlin? I think it's hard to know like what number we're going to be targeting for. There's estimates that range in terms of what level of herd immunity we need to be protective, and they range from 50% to 70%, 90%. I wouldn't. I think it's difficult to make a hard and fast rule on that, and really focus in on getting as many people vaccinated as we can to prevent infection in individuals, but also at the population level with blocking the spread.
Okay, next question is, when will we know how long the vaccine is effective for?
So we'll know as time goes on. Like I said earlier, the people in the clinical trials, they get followed for years to both see what their levels of antibodies are over time, but also to see if they develop infection. I think, time will tell. We've been fortunate to see that in the laboratory data that we collect shows that high levels of antibodies are maintained for several months. But that's as far as we've gone. Not enough time has been gone to say much further. It's gone by to say much more than that. And we also know that reinfection, so people that have had natural immunity and gotten infected, seems to be quite rare. So that's reassuring also that the immunity lasts, at least for several months, but I anticipate it'll be longer than that.
Okay, should I be concerned if I'm allergic to bees?
So with regard to the COVID vaccines, the current CDC recommendations are that people have had allergies to foods, to insect bites, to oral medications. Those would not be a contraindication to getting the vaccine and don't require any special measures. There isn't enough overlap between the ingredients in the vaccine and those kinds of allergens to warrant issues. The only real contraindication is someone who's had a true allergic reaction to the vaccine or one of its ingredients. Those people would be advised either not to get the second vaccine or to get the first vaccine if it's an ingredient specific issue. But with regard to like insects and foods, there isn't that kind of cross reactivity.
Okay, next one is, have you seen any patients who have had 2 vaccinations becoming sick enough to be admitted? How much sequencing are we doing in Connecticut to know whether the variants are having an effect here?
So 2 really good questions. In terms of people who have gotten sick from COVID requiring like hospitalization who've gotten the vaccine, we haven't seen that, at least here at UConn. And it's not being really described as being an issue. You know, there have been, I should say, there have been occasional reports. There was one patient, I think, in the Moderna trial who got the vaccine and got COVID and needed to be hospitalized. That was one out of, there were like 30,000 patients in the trial. So it can occur. Fortunately, seems to be quite uncommon. You know, with any vaccine, they're never going to be 100% effective. So I think, you know, it's important to keep that in mind, but also to kind of look and see that it's a pretty infrequent situation. With regard to the variants, you know, what the CDC has committed is that they'll provide resources to do 6,000 strains per week, or test for variants for 6,000 strains per week, which is a huge improvement. We were, as a country, only doing genomic sequencing for like a few hundred a week. So really ramping that up. And here in Connecticut, I don't know the exact numbers, but now we have multiple labs, including the JAX lab up here in Farmington and the Yale School of Public Health. And now the state public health lab in Rocky Hill is starting to do genomic sequencing. So we're really ramping it up at the state level. And I think that's going to be really important to be able to get the understanding of the variants that we need. Sorry, Kira, were there some additional questions?
Oh, I'm sorry, I was muted because we had noise in the background. Yes, if you receive a Moderna Pfizer vaccine and it ends up that we need a vaccine annually, will you need to receive the same brand going forward?
Oh, interesting question. You know, I don't think we have a clear answer on that one yet. You know, it is important to know that if you get your first dose of one, you need to get the same dose, the same brand of vaccine for your second dose. You can't kind of cross match those. But in terms of what the future is going to hold, just don't know if a booster dose is needed and how that's going to occur.
How do you find out what type of vaccine will be administered at each site?
It's variable. You know, some of it depends on what each site gets from the state, and the state, it depends on how much they get from the federal government. So the federal government oversees all the vaccine distributions throughout the country, and they allocate a certain number. They commit to a certain number of doses for each state, but they don't know in advance whether it's going to be X number of doses of Pfizer or Moderna or the J&J vaccine. You know, that they don't know until it's ready to be distributed. So, you know, some sites have been moving back and forth. Like for instance, here at UConn, our first amount of vaccine that we got was Pfizer. That was what we got from the state, and then we subsequently transitioned over to Moderna for first doses. We always make sure that we get enough doses for the second dose. So, for instance, for every first dose of Pfizer that we get guaranteed a second dose of Pfizer as well for that person. But sometimes it shifts, and it all depends on the federal government's distribution of vaccines.
Okay, just two more questions. This one actually kind of goes with the, what would be the effect of receiving a different mRNA vaccine on the second dose?
Don't know. Good question. I don't think we have any data to like guide us on that decision, because it's really something that we are not doing or discouraging from doing. So I don't think we can say for sure whether there would be negative consequences from kind of switching up and mixing doses, but something that we should try to avoid.
Okay. The last one I think I see here is, do you advise people with a history of Bell's palsy or Guillain-Barré to not get the vaccine?
So yeah, I mean, good questions. At this point, you know, the CDC guidance specifically says that history of Bell's palsy and history of Guillain-Barré are not contraindications to getting the vaccine. So that's what we generally use for our guidance for patients. You know, I think you know, it's still, you know, something that we have to keep an eye out for. You know, Guillain-Barré is something that's been seen with you know, flu vaccines in very rare situations. Most commonly, it occurs without a vaccine; it just occurs spontaneously. But something that you know, we're certainly watching, and it hasn't seemed to become an issue. But and at this point, it's not a contraindication to getting a COVID vaccine.
Okay, actually, thank you. That was I think that's all the questions that we have tonight. I think we're all very reassured by your talk. And thank you all for joining us. And thank you very much, Dr. Banach, for presenting this information to us tonight.
All right. Thank you for inviting me to come present.
You're welcome. Take care, everybody.
Have a good night.
Thank you.